Hello, everybody. Welcome to part 14 of our internal medicine review questions. So we're going to be going through a couple sets of questions here where we'll go through like 3 or 4 questions in a row, and you'll be expected to answer each one consecutively. You get these questions on the USMLE where they tell you, okay, you need to answer this, and once you choose your answer, you can't go back. So it's going to be important for you to get used to answering those types of questions, and we'll focus on that in this set. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos. You know, $1 a month, a little bit goes a long way. So thank you very much for your support, and thank you especially to those of you who have already donated. Okay, so we're going to start with question 1. We've got 3 questions here. We're going to go through each of the questions, and then we'll come back and we'll talk about each of them. I'm going to switch my pen to red here while we're at it. Okay, so we got a 38-year-old guy coming into the ED complaining of intermittent headache, malaise, and night sweats for the past few weeks. This has worsened over the past couple days, and he's recently had increased episodes along with blurry vision and diplopia. He is an IV drug user and was hospitalized 2 years ago for infective endocarditis. Vitals are pretty much normal with the exception of fever. He's ill-appearing. There are white plaques on the oral mucosa and disseminated flesh-colored umbilicated skin lesions approximately 5 millimeters in diameter. Increased resistance to passive neck flexion. Fundoscopy reveals papilledema bilaterally. Non-contrast head CT is unremarkable. Lumbar puncture is performed. CSF shows the following. You can read through those. Which of the following is the best treatment for this patient's condition? A. Ceftriaxone and vancomycin. B. Ganciclovir and foscarnet. C. Acyclovir. D. Aqueous crystalline penicillin G. Or E. Amphotericin and flucytosine. Okay, so this is a question that requires you to know the diagnosis, or the most likely diagnosis, and then from there, then you pick the treatment. Okay, let's move on to question 2. Appropriate antimicrobial therapy is administered. The suspected diagnosis is confirmed via further CSF studies. HIV test was ordered and was found to be positive. CD4 count is 45. While the symptoms initially improved over 48 hours, the headache has returned and he is experiencing worsening nausea, vomiting, and lethargy. Neuroexam shows no new focal deficits. Which of the following is the best next step in the management of this patient? A. PO dexamethasone. B. IV mannitol. C. IV caspofungin. Or D. serial lumbar punctures. Okay, we're going to move on to 3 here. 16 days later, the patient's symptoms have improved and repeat spinal fluid culture is negative. Which of the following is the best next step in the management of this patient? A. Discontinue initial therapy and begin daily flucytosine. B. Discontinue initial therapy and begin daily fluconazole. C. Discontinue initial therapy and begin daily acyclovir. D. Discontinue current antimicrobial therapy after antiretroviral therapy is started. Or E. Continue hospitalization and current medications for 5 more days and discharge. Okay, so let's go ahead and talk about this patient. So question 1, the answer was E. Amphotericin and flucytosine. What does this patient have? First of all, what's the underlying condition? So this is a guy who has AIDS. How do we know he has AIDS? Well, let's look at his history. He's an IV drug user. That's a big risk factor. He's got a history of endocarditis. Well, that's probably from the IV drug use, maybe not from the AIDS. But here's the big one. White plaques on the oral mucosa. What's that? Thrush. That's a fungal infection. In particular, that's opportunistic. Normal people don't get thrush. Okay, maybe you get thrush if you're on antibiotics, but you typically don't get thrush out of nowhere. Okay, sometimes you can get some cutaneous fungal infections. You know, that's not uncommon. You can get jock itch. You can get ringworm. You can get vaginal candidiasis sometimes, but typically you don't get fungal infections in the oral mucosa. Okay, that typically does not happen. Now, what about these disseminated flesh-colored umbilicated skin lesions approximately 5 millimeters in diameter? What's that? Molluscum. Okay, now, do ordinary people get molluscum? Yes, but usually it's a few lesions. If it's disseminated, you need to think of an immunodeficiency. Now, what kind of infection is molluscum? That's viral. So when you're talking about immunodeficiencies, what you need to think about is, are they predominantly getting bacterial diseases like sinopulmonary infections, GI infections? If so, that points more to a B cell issue, a humoral immunodeficiency like common variable immunodeficiency, X-linked agammaglobulinemia, things along those lines. On the other hand, if they have fungal and viral infections, that points more to a T cell disorder. And that can be acquired or it can be inherited. When it's inherited, it could be severe combined immunodeficiency. It can be ataxia-telangiectasia. It can be DeGeorge. There's a number of potentially inherited causes. But when you look at all those inherited causes, and you may get questions on that, with all of those, they get the typical constellation of opportunistic infections that we commonly see in AIDS. Now, this guy has all the risk factors of AIDS, and he's got the opportunistic infections. That points to that he has AIDS. Now, if this was a 2-year-old and mom doesn't have HIV and, along those lines, then you would be thinking of maybe DeGeorge syndrome. Get a chest x-ray, look for a thymic silhouette. Maybe it's ataxia-telangiectasia. Maybe it's Wiskott-Aldrich. There's a number of things that you might think of if this were a small child. But because it's an adult with risk factors for HIV, we got to think AIDS. Now, regardless of that, regardless of what the underlying cause is, what is the cause of this guy's acute presentation? Well, let's look at the way that this guy is presenting. So, increased resistance to passive neck flexion, along with a fever. What does that sound like? Meningitis. But wait, he's also got elevated intracranial pressure. He's got blurry vision, diplopia. He's confused. So that points to encephalitis, and that's what we call meningoencephalitis. When you have both meningitis, which is going to be your meningeal signs, but typically with just ordinary meningitis, they don't have altered mental status unless they're septic. But when you have that along with confusion and a headache, then that points to meningoencephalitis. Now, cryptococcal meningitis or cryptococcal meningoencephalitis is what we're dealing with here. Now, how do you know that? Well, first of all, cryptococcal meningitis is the number one cause of meningitis in AIDS patients. But beside that, what we can see here is that he has got a fungal picture in his CSF. So, for one, his glucose is low. If the glucose is low, that's telling you that there's something living in the CSF. So, it's not viral, for instance. Remember, living organisms eat glucose. So, the glucose will be low if you have a fungal, if you have a tuberculous, if you have a bacterial. Now, beyond that, what do we see? Lymphocyte predominance. So that gets rid of bacterial because bacterial would be neutrophil predominance. And then what else do we see? A really high opening pressure, and that is characteristic for cryptococcal. So you put all this together, you know what's going on. So now we can look at our answer choices and we can pretty easily eliminate. Ceftriaxone and vancomycin, what's that for? That's our empiric therapy for bacterial meningitis in a patient this age. If this were a guy that was 55 years old, he had the bacterial picture of meningitis, didn't have AIDS, then we would do ceftriaxone, vancomycin plus ampicillin because we need to cover for listeria in patients over the age of 50. But this is not bacterial meningitis, so we can get rid of that. Ganciclovir and foscarnet, what's that for? That's for CMV encephalitis. Okay, that would be a viral picture. So you'd have a normal glucose and you wouldn't have that high opening pressure. What about acyclovir? I apologize, my phone's going. So acyclovir would be for HSV encephalitis. We don't see that in this patient. That's unlikely given the low glucose, not a viral picture, and the very elevated opening pressure. So for similar reasons, that's gone. I'm going to briefly here turn my phone off. Okay. Aqueous crystalline penicillin G. What's that for? That's for neurosyphilis. That's not going on here. So it's amphotericin and flucytosine. That is our initial treatment for cryptococcal meningitis. All right, question 2. So you have this appropriate antimicrobial therapy, which is, of course, amphotericin, flucytosine. And now what they're telling you is the symptoms improved, but now the headache has returned. But he's not having any focal deficits. He's just got the headache and the nausea and the lethargy. What is that telling you? Elevated intracranial pressure. Remember that elevated opening pressure? All that's telling you is you've got a high intracranial pressure. Now, one of the classic features of cryptococcal meningoencephalitis is that they have a tendency to develop very high intracranial pressure, which is why that opening pressure is high. And the reason for that is patients with cryptococcal meningoencephalitis have a very high fungal burden, usually more than 1 million per cubic millimeter. That's a lot. And these yeasts and polysaccharides, they clog the arachnoid villi, and that blocks CSF outflow. So they get high amounts of CSF, and that's going to raise the intracranial pressure. Now, if you have high amounts of CSF causing intracranial pressure, what's the most obvious way to get rid of that? Drain the CSF. So serial lumbar punctures is what we do. Now, intravenous mannitol, could we do that? Well, that wouldn't be very effective. I mean, you could, but it probably wouldn't fix the problem. That would be something we do typically to decrease intracranial pressure in patients who've had trauma, intracranial hemorrhage, masses, so we don't do that. What about dexamethasone? When would that be an adjunctive treatment? So we might add dexamethasone. We would do it IV though, not PO, if the patient was presumed to have pneumococcal meningitis, but that's not this patient. And what about caspofungin? Caspofungin is an antifungal, but it is not used for cryptococcus. It's good for very severe candidal infections. It's good for disseminated aspergillosis, but it has no role in cryptococcus. Okay? So this is pretty much what you do. You do these serial lumbar punctures, and you're going to do it until the symptoms abate. Now, this is important because this intracranial pressure will continue to rise, and they'll begin to develop these symptoms of high intracranial pressure: headache, vomiting, visual changes, cranial nerve palsies, and eventually that can cause herniation. So this is really important that you deal with this. All right, I think that's all I wanted to talk about here for this. Okay. Now, what about question 3? 16 days later, his symptoms improved, and the spinal fluid culture is negative. So what do we do now? So what this is requiring you to know is that these patients are not going to be on amphotericin B and flucytosine forever. Okay, you'll do amphotericin B and flucytosine for at least 2 weeks, but if their symptoms don't improve or they continue to have cryptococcal antigen in their CSF, or their CSF is still abnormal, you will continue that therapy and they'll continue to need to be in the hospital. So it's not hard and fast 2 weeks, but 2 weeks is the minimum. So if we were to say 6 days later, his symptoms improved and the spinal fluid culture was negative, we would still need to go another 8 days. But because this is 16 days later, he's past the 2 weeks, he looks good, we can stop the amphotericin B and flucytosine, and then our next treatment then is to send him home on PO high-dose fluconazole. That's an antifungal. Okay, and he'll be on that for some time, and so that's going to be your next step. So A was daily flucytosine. No. You need to have an antifungal, and that's fluconazole. What about daily acyclovir? No, because this is fungal, not viral. What about discontinue current antimicrobial therapy after antiretroviral therapy is started? Well, certainly he's going to need to go on antiretroviral therapy. He's got AIDS, but you have to continue the antifungal treatment, and this is going to need to continue for about at least a year. So that's gone. What about continue hospitalization and current medications for 5 more days? No, he's past the 2-week point. He doesn't have symptoms. The CSF is normal, so we don't need to continue hospitalizing him. And so the answer is B. So cryptococcal meningitis is the leading cause of meningitis in AIDS patients. The highest risk is when the CD4 count is less than 50. That's probably what they'll give you on the test. They'll probably say CD4 count of 38 or 46, but it doesn't have to be. Okay, you can get cryptococcal meningitis or meningoencephalitis if the CD4 count is higher. It's just your risk is highest below 50. Clinical features: subacute meningoencephalitis, fever, nausea, vomiting. Altered mental status, headache, and meningeal signs can be seen. Now, you'll also often have symptoms of elevated intracranial pressure. Now, this is important. This is what I wanted to go through, but I couldn't remember what I wanted to tell you. So let's go back here real quick. Why did we do here it is. Why did we do the non-contrast head CT before we did the lumbar puncture? Because when you have a patient with symptoms of high intracranial pressure, you never want to do a lumbar puncture first. Okay, because you don't know where that high intracranial pressure is coming from. Now, in this case, we were able to do it because the high intracranial pressure is due to high amounts of cerebrospinal fluid. But if it was due to a tumor or something like that, we would not want to jump to a lumbar puncture. So we have to do the imaging first. Okay, if you've got focal deficits, if you've got altered mental status, if you've got a papilledema, signs of high intracranial pressure, you want to start with imaging and then do the lumbar puncture. Okay. Now the workup, of course, head CT, because these patients typically have high intracranial pressure, then do the lumbar puncture with CSF analysis, and you can also get the cryptococcal antigen. That would be really specific, obviously, for cryptococcal disease. You'll have the elevated opening pressure, increased cell count. That's going to be lymphocytes because this is not bacterial. Increased protein and decreased glucose because this is an organism, not a virus. The treatment, amphotericin B and flucytosine for at least 2 weeks. Once you have clinical improvement and normalized CSF, switch them to fluconazole. That will continue for at least a year. Now, it's recommended you defer ART, antiretroviral therapy, until the induction phase is complete. And the reason for that is you want to avoid reconstitution syndrome. So immune reconstitution, inflammatory syndrome can be really, really bad. You typically don't want to start antiretroviral therapy while a patient has an AIDS-related infection. That's a general rule of thumb. Now, you got to know your CSF analysis. Very important. Do you need to know these numbers? No. But what you do need to know is what's elevated, what's normal, what's low. And you want to know for bacterial, for viral, for fungal, for tuberculous. You want to know normal too. Now, you'll be given the normal values, but you won't be told on your lab sheet that you've got on your test, bacterial is going to be high protein, neutrophils, low glucose, and so forth. So you need to know that, but the numbers, those will be given to you. Okay, let's move on to question 4. 30-year-old woman presents to the clinic complaining of intermittent dizziness, weakness, and clumsiness for the past few months. Until now, she's dismissed this as fatigue. She works late hours and only gets about 5 hours of sleep per night and says she doesn't eat properly. However, earlier this week, she developed visual changes and left eye pain. Upon further questioning, she says that last year she had an episode of numbness and tingling of the right hand, which improved before she could see her physician, and she canceled her appointment. Vitals are within normal limits. Neuroexam reveals decreased visual acuity in the right eye and an afferent pupillary defect. Oh, sorry, this should be left eye. Okay. An afferent pupillary defect. Lower extremities have spastic paresis, hyperreflexia, and a positive Babinski sign. Which of the following is the best test to confirm the most likely diagnosis in this patient? A, visual evoked potentials. B, MRI for brain and spine. C, non-contrast CT of the head. D, EMG and nerve conduction studies. Or E, lumbar puncture. Okay. So move on now. We're going to move on to question 5. The appropriate test is performed and confirms the diagnosis. Which of the following is the best next step in the management of this patient? A, intravenous immunoglobulins. B, intravenous methylprednisolone. C, emergent plasmapheresis. D, pulse dose cyclophosphamide. Or E, oral prednisone. Okay, we're going to move on to the next question here. After appropriate therapy, the patient's symptoms improve within a few days. She's referred to a neurologist for long-term treatment. Which of the following is the most appropriate long-term treatment for this patient? A, pramipexole. B, low-dose prednisone. C, interferon beta. D, rivastigmine. Or E, topiramate. And I got my loud neighbors again. Every time I put a video together. Okay, we'll move on to question 7 now. Several months later, the patient returns due to painful muscle spasms in both legs, which come on particularly after getting up from sitting or laying for prolonged periods. There are no other neurologic deficits. Increased muscle tone in both extremities, BMP, CBC, and serum calcium are within normal limits. Along with physical therapy and stretching exercises, which of the following agents would most likely bring symptomatic relief to this patient? A, high-dose prednisone. B, pyridostigmine. C, baclofen. D, amantadine. E, indomethacin. Or F, benztropine. All right, let's go ahead and look at the answers for question 4. So question 4 was MRI of the brain and spine. What does this patient have? This patient has MS. How do we know she's got MS? Well, first of all, the classic findings of MS is where you get neurologic signs that come and go. And not only do they come and go, but they're in all sorts of different places. So look, right now she's got dizziness, weakness, and clumsiness. Okay? Then she developed visual changes and left eye pain. What's that? That's optic neuritis. Very classic with MS. Now, last year, she had numbness and tingling of the right hand. So you see all these kind of neurologic symptoms that come and go, and they don't really relate to each other. Okay, it's not like she had a sudden onset of hemiplegia that went, that would be like a TIA, for instance, and maybe something vascular. These are all over the place, and they don't really have any relation to one another. So when you have these neurologic deficits that are separated by time and space, that is multiple sclerosis. When you have a patient, a young woman that develops optic neuritis, which is monocular vision loss with eye pain with movement, that is MS until proven otherwise. When you have upper motor neuron signs, spastic paresis, hyperreflexia, positive Babinski, those are upper motor neuron signs. That's telling you something's going on in the brain or spinal cord. This may be due to possibly a transverse myelitis. We don't really know. Maybe plaques in the spinal cord. So we don't know. But that's upper motor neuron, again, consistent with MS. So the patient most likely has MS. What this is asking you is how do we diagnose it? And the diagnosis for MS is going to be a T2 weighted MRI. Okay, that is our answer here. Now, what about visual evoked potentials? Could we use that for MS? Well, yeah, you could. That would be the test that we would do if she had metal in her body, if she had a pacemaker or something like that. And you could go ahead and do that. It's not as good, but if you can't do an MRI, this is what you'll go with. Non-contrast CT of the head, when would we do that? That's something we would do if we thought she was having a stroke, okay? Not this patient. She's 30. She's got chronic neurologic signs, not all of a sudden, so it's not a stroke. EMG and nerve conduction studies, what about that? That's going to look for lower motor neuron problems. Okay, nerve conduction studies, we're looking at the peripheral nerves. EMG, we're looking at how the muscles respond to the nerves, how they respond to an electrical impulse. So that's not going to be useful. What about lumbar puncture? So it's not the best initial test for MS, but it could be used if you had equivocal findings. Not all the time are you going to find an MS patient that has really evident disease on MRI. So you could do a lumbar puncture, but it's not the first test we go for. But what would you see? Oligoclonal bands. And in particular, those are IgG. But that is not the first test that we do. We do an MRI of the brain and spine. We can see those plaques. It's diagnostic for MS. Okay, what about question 5? Why do we use IV methylprednisolone? So this patient is having an MS flare. Okay, she's got neurologic signs in the context of MS. Okay, so that's an MS flare. So an MS flare is treated with steroids. Now, you have 2 steroids here. You have oral prednisone and IV methylprednisolone. Why the IV methylprednisolone? Because she's got optic neuritis. So if you have optic neuritis, you must use IV steroids. If she didn't have optic neuritis, you could choose between the 2. Usually we do the IV steroids, works faster, but you could do oral prednisone. But because she's got optic neuritis, you must choose IV steroids. If she didn't have optic neuritis, if she just had, clumsiness, weakness of the left leg or something like that, then you wouldn't be given both of these. You'd be given one or the other because they would both be, right. Okay. Now, what about IV immunoglobulins? Would we ever use that in MS? No. Not enough evidence for use in MS flares. That's gone. What about plasmapheresis? Would we ever use that in MS? We could. But steroids are first line. So if they don't respond to IV steroids, you could consider plasmapheresis, but it certainly wouldn't be done emergently because you would start with steroids. So that's gone. What about pulse dose cyclophosphamide? We use that? No, not enough evidence. That's not used here. And then we talked about the difference between IV and oral prednisone. Okay, now question 6. This is asking you long-term treatment. Do we want to have a patient on long-term steroids? Well, it would work, but we don't want to do that. This is a young woman. She's 30. We would screw up her appearance. She'd get all the Cushing signs. We would put her at risk for osteoporosis. I mean, lots of nasty things. So we don't want to ever have somebody on long-term steroids. That's out. Pramipexole, what's that? That's a dopamine agonist. When do we use that? In Parkinson's. She doesn't have Parkinson's. What about rivastigmine? Yeah, that's not going to be used here. That's an acetylcholinesterase inhibitor. That is something we use for mild to moderate Alzheimer's disease. Definitely not this patient. What about topiramate? Again, we don't use that here. This is for seizure disorders and migraine prophylaxis. Okay, so the answer is interferon beta. Now, another drug that you can use for long-term maintenance of MS, glatiramer. Okay, you'll never be asked to pick between that and interferon beta. You'll be given one or the other, but you should know both because this question could have easily given you glatiramer instead of interferon beta. And if you just know interferon beta, you'll be looking at this, be like, I don't know, they all look wrong. So you need to know both. Okay, question 7. What's going on now? So she's been good, and now several months later, she's got muscle spasms. Is this an MS flare? No, MS flares are always neurological. This is muscular. These muscle spasms are very common with MS, okay? This is a comorbidity with MS, and usually it involves the lower extremities, and it's worse after rest. So maybe when they wake up in the morning, if they work a desk job, they've been sitting for 4 hours, they'll stand up, and their legs will just be killing them. The first line therapy for MS-related spasticity, which is what this is a muscle relaxant, like baclofen. Okay, that's what we want to use here. Now, what about high-dose prednisone? That's what we would do if this was an MS flare. This is not. What about periodostigmine? Periodostigmine would be used for myasthenia gravis, and that would be weakness, not spasticity. And remember, myasthenia gravis, it can, but doesn't typically affect the big muscles. It usually affects the smaller muscles of the face and neck. Okay, it can affect other muscles, but that's not this patient. She's got optic neuritis, or she has had it. We already know that she's got characteristic findings on MRI. I'm going to show you some pictures of those in a little bit. So that's not it. What about amantadine? So amantadine does have a role in MS, but this is for MS-related fatigue. Okay, so this is a drug you can use for MS-related fatigue. You can also use stimulants. What about indomethacin? Nah, that would be if it was an inflammatory pain. What about benztropine? Benztropine is used for a kind of spasticity, but not this kind of spasticity. If this were a patient that had muscle spasms and she was on long-term haloperidol, then we would think of dystonia. We would think of one of those extrapyramidal symptoms you can get from being on antidopaminergics, like antipsychotics. This patient has MS. She's not on antidopaminergics. She's got intermittent symptoms. This is not something that we would use benztropine for. If she were on antidopaminergics and she had spasticity, then we would think about benztropine. So these are your clinical features of MS. So optic neuritis is a big one. That's probably going to be on your test. Intranuclear ophthalmoplegia, you can look up the pathophysiology of that. High yield for step 1. Just know kind of how it looks if you're approaching step 2 or 3. Lermet sign, that's when you lift the neck and they get an electrical sensation down their back. And of course, fatigue, head sensitivity, sensory motor symptoms, bowel bladder dysfunction, and the big one, neurodeficit separated by time and space. That's your dead giveaway. Now, the onset is usually early adulthood to middle age, particularly women. There's a female preponderance. The disease pattern can come in a variety of ways. Relapsing remitting is the most common. I'm going to show you, though, these different kinds in a graph, which will help you. The diagnosis, T2 MRI is what we go for, and you'll see these different lesions. And then CSF, if you did get that, you would see oligoclonal bands. That can come up on your test. They can give you a patient with MS and say, what would you expect to see in the CSF? That would be a classic step 1 question. Okay, so this is an MRI of a patient with MS. What do you see here? Look at these little things coming up like that. What are these called? Do you know what these are called? Dawson fingers. Classic finding of MS. You should know this. So these little white matter lesions, or these little lesions that come out around the lateral ventricles. That's all it is. So here you can see lesions within the cortex, or subcortical area, rather. So here, here, here. This is all same patient. So you can see lesions all over the place. These white matter lesions, they're very easy to identify, and you'll have your diagnosis right there. Now you can also see white matter lesions in the spinal cord. So here, this is what could have caused spasticity. Okay? But it's all upper motor neurons. So you wouldn't see any kind of lesions in the peripheral nerves. That's not how MS works. Okay, so there are a few different, and I'm going to switch my pen to black here. There's a few different ways that MS can progress, and I'm going to show you them now. So the first is the most common kind, and that is called relapsing remitting MS. So relapsing remitting MS. So the way this works is that they're at baseline, and then they have a flare, but then they don't ever really come back to baseline. So they have a new baseline. And then they'll have a flare, and they don't come back to baseline. They have a new baseline, and then this just keeps occurring. and eventually, they become very severely impaired. However, they can go a very long time. They could go 30, 40 years and not really have serious impairment, but it will get worse over time. Okay, so that is relapsing remitting MS. Now, there's also primary progressive MS. Okay, and this is simple. They don't really have flares. Things are just getting worse and worse and worse for them. Okay, that's kind of the worst one to have because you're never going to get better. Now, there's also secondary progressive. This is kind of a combination. So this starts out looking a lot like relapsing remitting, like that. But then they hit a point and then they just get worse and worse and worse, like primary progressive. And then there's one more, and that is progressive relapsing MS. And that's basically where they never go back to baseline. So they'll have flares and then they continue to get worse, and a flare and they continue to get worse, and a flare and they continue to get worse. What you need to know, relapsing remitting MS is the most common cause, or the most common variant. On your test, what you could be given is these 4 charts, kind of like this, these 4 graphs, and they'll ask you to pick the most likely, the most common form of MS. And so you would pick the relapsing remitting. Okay. So your symptomatic management, you will likely with MS be dealing with a lot of comorbidities. So we talked about the general long-term treatment of MS being primarily interferon beta or glatiramer, but you'll also do a lot of treating of comorbidities. So patients with MS are at higher risk for depression. You just treat that like any other depression with SSRIs. Spasticity, we talked about that. Physical therapy, stretching exercises are great, but a lot of these patients will be in pain. So baclofen, or an alternative would be tizanidine. Fatigue, a lot of these patients are going to be tired a lot. So lifestyle modifications are always good to go with, to start. I mean, that's good for everyone. Good sleep hygiene, regular exercise. You can use amantadine. We talked about that. You can also use stimulants like methylphenidate or modafinil to keep them awake during the day. Neuropathic pain, pretty much the same that we treat neuropathic pain in anyone, gabapentin or duloxetine. They can get urge incontinence because of the upper motor neuron symptoms. So you can do things like time voiding or fluid restriction. You can also use anticholinergics like oxybutynin or detraltoterdine. Okay. So basically, I mean, with these, it's the same way you treat them in everyone else for the most part. Okay, question 8. We got a 60-year-old guy coming into the clinic complaining of cough over the last 3 months. He had initially attributed the cough to allergies, but is concerned because he has had 3 days of blood-tinged sputum. He was most recently seen 6 months ago for a regular annual physical and has unintentionally lost 10 pounds since then. He denies fever and night sweats. He has a past medical history significant for mild COPD. Vitals show blood pressure 125 over 77, heart rate 80, respirations 15, temperature 98.6, saturation 99% of room air. His BMI is 19.9. Lung auscultation reveals rales in the left upper lung fields. BMP and CBC are within normal limits. Serum calcium is 12.5. Chest x-ray shows a 3 centimeter mass in the left upper lung field. Sputum cytology reveals poorly differentiated squamous cell carcinoma. PFT reveals an FEV1 of 1150 cc's. A VQ scan shows 63% of his pulmonary function comes from the left lung. Which of the following is the best next step in the management of this patient? A, left upper lobectomy. B, left pneumonectomy. C, CT scan of the chest. D, radiation and chemo. Or E, referral to oncology. Okay. Let's go for the answer here. So this CT scan of the chest, what does this guy have? He's got lung cancer. Okay, we knew it from the beginning. You got a guy who's a smoker. He's coughing up blood. He's lost weight. He's got COPD, so we know he's got an extensive smoking history. I mean, that all points to lung cancer. This is classic lung cancer. You might be thinking, get really excited when you're reading this and, oh, I know what it is. And then they come at you and they're like giving you something completely different rather than what's the diagnosis. Now, we would look at the serum calcium and we would see that's high. We know that Hypercalcemia of malignancy is a common paraneoplastic syndrome, especially in squamous cell cancers. But then they tell you, it's got squamous cell carcinoma. So once again, you're left thinking, what are they going to ask me? And this is a reason I'll just add here as an aside. When I approach test questions, what I do is I quickly look at the question at the end. So here they're asking for best next step in management. And then keep that in mind. It'll help you filter what's important information for you to know. Because otherwise you're going to have to go back and read everything again. So it could save you some time. Make sure, though, don't read the answer choices until you get an idea of what you think might be going on. Because if you think you know the answer and then you see it in the answer choices, really strong chance that's right. You don't want to read the answer choices first because you might get distracted. Okay, going back to this, we know the guy likely has lung cancer. What do we have to do? We've got to get a CT, okay? So lung cancer, the treatment depends on the histologic type, which we know is squamous cell, but also the stage. And when we stage, we use the TLM system, T being the extent of local spread, L for nodal involvement, and M for whether or not there's metastases. So what we're going to look for in the CT of the chest is we're going to look for local spread and the size of the cancer. We're also going to look at whether or not there's nodes, mediastinal lymph nodes. And if there are, then that's going to affect our stage. Now, are you going to be expected to know how to stage lung cancer? No. However, you do need to know that the treatment will differ based on the stage. And so for that reason, when you are pretty sure a patient's got lung cancer, you need to do a CT. You can't jump right to treatment. Now, it is good that you do the lung function evaluation. That's important. And we did that here. You get the FEV1, you get the VQ scan. That's going to be something you have to do if you're going to do surgery, but you got to get that CT so that you can stage this cancer. Because if you don't stage the cancer, you can't go for treatments yet. So A and B, those are surgical resections of the lung, whether that be just the lobe or the entire lung on one side. That would be a treatment, and these would be done for stage 1 or 2. But if the patient had stage 3, they probably wouldn't benefit from that as much. So you need to stage first. What about D, radiation and chemotherapy? Well, again, that's something that you might do, but you've got to get the CT. And not only do you have to get the CT to stage, but when you're talking about radiation and chemotherapy, you want to get a baseline CT so that you can see how the tumor is responding. You want, of course, for it to be shrinking. So these are all out. What about referral to oncology? Well, you got to do all the things that you can do first. Oncology is going to say, okay, this is how we do the radiation. This is the chemo regimen you're going to be on. But it's ideal. And if you've done rotations with specialists like GI or nephrology or whatever, they're going to look at all the things that the primary care physician did first. And they want you to do your due diligence so that you're not sending them to do, basic workups. You want them to be spending their time focusing on the specialty aspect of things. So referral, generally speaking, on step 2 is going to be the wrong answer. On step 3, it could be the right answer, but referral would be something where none of the other answer choices are right. There's something else that you need to do. So maybe it's some kind of difficult surgery, like a ophthalmologic surgery or something like that. If none of the other answers look right, the referral is usually like a none of the above answer choice. That's the way I like to look at it. So this is wrong because we know we can do the CT of the chest. That's super, super important. So when you got a patient with newly diagnosed lung cancer, you want to do a CT. That's going to tell you if maybe you can do the biopsy. Remember, we can do biopsies 2 ways, CT guided, or we can do bronchoscopy. And then you need to do your pulmonary function tests, and that's going to be basically an FEV1 and a VQ scan. That's going to be important preoperatively. Okay, we got a 30-year-old prima gravida, so we're going to get a little bit of obstetrics here. She presents to the clinic for her first prenatal appointment. She's 9 weeks gestation based on LMP. She describes fatigue, intermittent nausea, and anorexia. She also describes fever, night sweats, and dry cough. She has no significant past medical history and only takes a prenatal vitamin. Her mother recently visited from Uganda, but had to return early due to illness. Vitals are within normal limits aside from a mild fever. Fine crackles are heard over the right posterior thorax. Remainder of exam is unremarkable. Chest x-ray reveals a right upper lobe infiltrate with a small cavity. 3 sputum samples are positive for acid-fast bacilli. All appropriate first trimester labs are normal. Which of the following is the best next step in the management of this patient? A. Isoniazid and pyridoxine, followed by repeat sputum acid-fast bacilli. B. Termination of pregnancy due to teratogenic effects of the necessary treatment. C. Start multi-drug anti-tuberculosis treatment. Or D. Delay treatment until childbirth. All right, what are we going to do here? What does she have? So let's look at the answer. So the answer is to start multi-drug anti-tuberculosis treatment. So this is a patient who is pregnant and she's got active TB. How do we know she's got active TB? Well, number 1, she's symptomatic. Number 2, we did a chest x-ray and we found a cavity exactly where we'd expect to find it in TB in the upper lobes. And then, of course, the dead giveaway is that her sputum samples were positive for acid-fast bacilli. Now, there is something called latent TB. Latent TB is something that you would typically diagnose when you get a Manto test, and then you see the high amount of induration, and then you do a chest x-ray, right? If there were no symptoms, if there was no sputum acid-fast bacilli, then that would be a diagnosis of latent TB. Okay, but that's not going on here. So A, isoniazid and pyridoxine followed by repeat sputum AFB. What would that be for? This would be the treatment for latent TB. Now, in a pregnant patient, we do not need to treat her for latent TB while she is pregnant. We could, but we don't have to. And typically most women, when they're pregnant, do not want to be on medications if they don't have to be on them. So this is out. She does not have latent TB. She has active TB. What about termination of pregnancy? No. As a matter of fact, the drugs that we use in TB are fairly safe. And then what about delay treatment until childbirth? No, we have to treat the TB now. Active TB needs to be treated now. Latent TB can wait. Active TB needs to be treated now. Now, there's a little bit of a difference here between how we treat TB in pregnancy and how we treat it in non-pregnant patients. In non-pregnant patients, we do RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. However, in a patient who is pregnant, we don't use pyrazinamide. So we just do 3 drugs. So this is for pregnant patients. And the reason is because pyrazinamide, while we use it as our traditional therapy for TB, it's unclear how much pyrazinamide actually helps. And it also happens to be the one here that may be the most teratogenic, if any of them are. So we can get rid of that. But in a non-pregnant patient, we would include it. So you may get asked about the timing of the treatment. So for the first 2 months with the RAE therapy, the triple therapy, you would use isoniazid, rifampin, and ethambutol. And then, of course, you always will add pyridoxine anytime you're using isoniazid, and you would use those 3 drugs for 2 months. Then you get rid of the ethambutol and you just use isoniazid and rifampin and, of course, B6 for 7 more months. Okay, that is our treatment regimen for pregnant women who have active TB. Okay. Now, let's look at these symptoms, though. Fatigue, intermittent nausea, and anorexia. Is that concerning in a pregnant woman at this stage in her pregnancy? Heck no. Okay? Yes, you get tired when you're pregnant. Yes, you get nauseous when you're pregnant in the first trimester. Yes, you can be anorexic anorexic here, anorexia, all that means is no appetite. We're not talking about anorexia nervosa. So anorexia here, loss of appetite. Well, yeah, if you're puking a lot, you're not going to exactly want to be eating hamburgers. Okay, let's move on to our last question. A 27-year-old man is brought to the ED by his mom due to agitation and confusion over the past 2 hours. He has a history of treatment-refractory major depressive disorder. She said that he recently lost his job and has been feeling down for the past week. His medications include amitriptyline and zolpidem. Vitals show blood pressure 90/50, heart rate 115, respirations 23, temperature 102.1. He is visibly confused and cannot answer questions. There's facial flushing, mydriasis, and hyperreflexia. EKG reveals wide complex tachycardia. Sodium bicarbonate infusion is started. Which of the following is the purpose of this intervention? Another kind of step 1 question, but you're getting more of these on step 2 and 3. A, prevention of seizures. B, treatment of hyperkalemia. C, alkalinization of urine. D, correction of metabolic acidosis. Or E, prevention of arrhythmias. All right, what is our answer here? Prevention of arrhythmias. I bet you were thinking alkalinization of urine so we could get rid of this. What's going on here? Well, he's got amitriptyline prescribed. He just lost his job and has been feeling down, and now he's coming in with all these anticholinergic signs. What is that? TCA overdose, okay? Probably intentional, but it doesn't matter right now. We need to treat him for the TCA overdose. Now, we often give sodium bicarbonate for a TCA overdose. Why? Do we do it because they have metabolic acidosis? No. They may have metabolic acidosis, but that's not why we're treating it. Or that's not why we're using bicarb. What about alkalinization of urine? Will that help you get rid of tricyclic antidepressants? Yes, but it's not useful here because tricyclic antidepressants have a very high volume of distribution, and it's not going to help you excrete it very in any significant way. Now, if we're talking about a salicylate toxicity, if you took a bottle of aspirin, that would be useful. That would help you get rid of the salicylates. Okay, so both of these are out. What about treatment of hyperkalemia? Well, it would help with hyperkalemia, but that's not the rationale here. Okay, the rationale here is that this is going to help with arrhythmias. And then prevention of seizures, no, it wouldn't even do that. We'd use benzos for that. So bicarbonate actually has a cardioprotective effect when you have a patient with TCA overdose. And we'll talk about why that is in the next slide. Okay, so let's talk about how TCA patients come in. So TCA overdose patients are most prominently going to have CNS symptoms and anticholinergic symptoms. Cardiovascular, yes, they can. It's mostly going to be hypotension, but all these more specific things, you're going to see them on EKG. Okay, so let's talk about CNS. What are they going to have CNS related? Typically, it's just going to be the mental status changes. So they'll be confused, agitated, won't be able to answer questions. That's not super specific. But what about the anticholinergic symptoms? That's a little bit more specific for TCA overdose. TCAs are anticholinergic, so you can get these signs. And remember your mnemonic for anticholinergic toxicity. Mad as a hatter, so confusion, altered mental status. Hot as a desert, so hyperthermia. Blind as a bat, mydriasis. Red as a beet, flushing. Dry as a bone, dry mouth and urinary retention. And there's other symptoms too. So that is a way that you can remember it. There's all sorts of mnemonics. Another way that you can remember it basically is if you remember your dumbbells mnemonic for cholinergic toxicity, it's just all the opposites of that. So instead of pinpoint pupils, you have mydriasis. Instead of salivation, lacrimation, you've got dry eyes and dry mouth. Instead of urinary incontinence, you have urinary retention, and so on and so forth, okay? Now, what about the cardiovascular manifestations? Typically, the first thing you're going to see is hypotension, then you get an EKG. what you'll usually see is wide QRS complex tachycardia. And that is why we give the bicarb. It is to prevent arrhythmias. Arrhythmias are the #1 cause of death in tricyclic antidepressant overdose, the cardiotoxic effects. We need to prevent that. So basically, what these TCAs do is they have some fast sodium channel inhibition properties, kind of like your class 1 antiarrhythmics. And so because of that, they widen your QRS complex. If you remember when I talked about antiarrhythmics that block sodium channels will widen the QRS. Okay, and so this does the same thing. It widens the QRS, and that raises your risk of arrhythmia. It can also reduce calcium influx into the myocardium. That can cause a PR prolongation. Anything that prolongs the PR is generally going to cause bradycardia, but typically it's not severe enough to cause bradycardia. So usually what you're going to see is a wide QRS complex tachycardia. Okay, and this can then lead to VTAC or V-fibrillation, and that is why we give the sodium bicarb. Okay, the sodium bicarb, it corrects the acidosis, but the bigger thing that it does is it increases the serum sodium, and that is the antiarrhythmic effect of the sodium bicarb. So usually we give sodium bicarb if someone's got a metabolic acidosis and their pH is less than 7.1, or they took a bunch of aspirin and we want to get rid of the metabolites. We want to flush it out of their body, get it into the kidneys, get it into the urine. But that is not the rationale here. The rationale for TCA overdose is that we are preventing arrhythmias. Okay? So supportive care and treatment. Supplemental oxygen, intubation if needed, if their respiratory depression is really bad. IV fluids, and then of course the IV sodium bicarb. We would only give that if they have wide complex tachycardia, but that's going to be most of the patients. A lot of physicians won't even wait for the EKG. They're just going to say, if they got tachycardia, start the sodium bicarb. Sodium bicarb is fairly safe, especially at the doses that we would use. So, you're better safe than sorry. If they came in and mom said, I saw him, chugging a bunch of pills, that was 30 minutes ago, go ahead, activated charcoal, NG flushing, totally fine. But if it was, we don't know how long ago it was, 3 hours, 4 hours ago, it's not going to be useful. That stuff's not going to be in the stomach anymore. So I think that's pretty much all I want. Okay, we can... Oh, no, we already went over that. Okay, so that is all I've got for you. If you have any questions, write me a note below.